everyone. Thank you for joining us for this installment of the Root Cause Coalition's 2018 How-To Webinar Series. Before we get started, I wanted to run through a few features of today's webinar. All of our attendees will be in listen-only mode for the duration of the webinar. At the end of this webinar, our panelists will be answering audience questions. If you have a question during the webinar, please type your question into the question pane on the webinar panel located usually at the right side of your screen. This webinar is being recorded and will be available for download on the Root Cause Coalition website later this week. Thank you all again for attending, and at this time I'm going to pass it over to our presenters.
Thank you very much, Monique. We are super excited to be hosting this webinar of how to utilize funding mechanisms to address housing as a health issue. My name is Kelly Bruno, and I am the President and CEO of National Health Foundation, and I am delighted to be joined with two of our amazing partners in recuperative care here in Los Angeles on this webinar. And I'm going to take a brief moment to have each of them introduce themselves to you and tell you a little bit about what roles they play in their respective organizations. And we'll start with Dr. Kagan.
Hi, good morning, everybody. My name is David Kagan. I'm one of the medical directors at LA Care, and I'm here with one of my colleagues.
Hi, my name is Jessica Ju, Senior Program Manager with the Safety Net Initiatives Department at LA Care.
Thank you very much. And Kim, could you introduce yourself, please?
Yes, my name is Kim Hurley. I'm the Director of Population Health Social Services for Dignity Health Enterprises, and I'm responsible for assisting the hospitals with working with the community to solve some of our transition concerns from patients leaving the hospital.
Great. Thank you both very much. And I'm so happy that both of you are here. I think together we're going to be able to give a very good overview and perspective of recuperative care services and the benefits both fiscally and also to the clients. Today what we're hoping to accomplish, if I can advance the slide, Monique, maybe you could help me, is a few things. Let's see. There we go. First, we want to talk a little bit about recuperative care and what that is. We're going to give you an overview of the different funding models for recuperative care, and then Kim's going to speak a little bit about Dignity Health System's rationale for participating. Dr. Kagan will then join in with LA Care's rationale as a health plan, and then we'll spend a few minutes talking about the future of funding and potential reimbursement strategies for medical respite. And then finally, we will close with some questions from you that hopefully we'll be able to answer. So let's begin. Recuperative Los Angeles, and I know a couple other places in the country, but we call our medical respite recuperative care. And Los Angeles has, as I'm sure many of you know, a very large population of individuals experiencing homelessness. So recuperative care has been around for some time. National Health Foundation's program really began about 10 years ago as a response to our hospital's need for an appropriate place to discharge their patients experiencing homelessness when they left the hospital. And there really was a dearth of services and locations to do that. So our funding models really came from the need and really morphed out of what was possible. When we started 10 years ago, our funding model was very much a fee-for-service contract. Hospitals had clients there, hospitals had individuals experiencing homelessness in their hospitals that needed a place to go. They had no place to send them. So we were able to make the fiscal argument and show that it was less expensive, obviously, for us to have those individuals with us than it was for them to stay in the hospital. Los Angeles has a little bit of a unique situation insofar as our city attorney has been prosecuting hospitals for what they call alleged patient dumping. So there was a lot of political pressure as well on hospitals, making it a very difficult situation. So recuperative care allowed for the opportunity for hospitals to have that appropriate place for discharge. So the fee-for-service model is really where recuperative care started as far as funding. Now, recuperative care is an unlicensed unregulated program across the country. And so because of that, it wasn't easily reimbursed by a health plan or insurance or anything like that. So the hospitals were paying for that and paid for that directly out of pocket. So it is a pay in the arrears model, similar to any other fee-for-service program. A client would come to us from the hospital, and we would keep them for a predetermined amount of days that we would determine with the hospital, and then we would bill the hospital in the arrears for that. So we would send a bill monthly, itemizing the clients that were with us or their patients that were with us, how long they were with us, and then they would pay us for those days. The fee-for-service, or the amount of the per day per diem, ranges in Los Angeles from providers, but it's roughly anywhere between, I would say, $200 and $250 a day currently for that. So it's very much a basic fiscal model, and it worked very well here in Los Angeles for several years for a number of reasons. But the primary one is because of, quite honestly, of just the sheer number of individuals who need the service, and also the sheer number of hospitals that are here to be able to support that fiscally from the provider's perspective. So we currently contract with over 70 hospitals here in Los Angeles to keep our recuperative care beds open. And up until about 2 weeks ago, we had 40 beds. Another county that's very close to us, which is Ventura County, was also extremely interested in having a recuperative care program in their county. However, their county is much smaller, the number of hospitals much, much smaller, and from a fiscal perspective, made it difficult for us to create a fiscal model that would assure sustainability. I should say that in the model, the first model that I discussed, because of the number of hospitals and the fee-for-service model, we were able to sustain the program because of the traffic and the number of individuals we could serve. In Ventura County, there were only 5 hospitals. And so our concern is that despite the need, that sustainability could become an issue. And so in order to address that issue or that concern, we created a public-private partnership with both the County of Ventura as well as the private hospitals in Ventura. And we're able to open a small 12-bed recuperative care facility where the costs were shared between the 5 participating hospitals, the 4 private hospitals and the 1 county hospital. And what we did was we surveyed those hospitals before we opened, asking them for self-reported numbers of those individuals experiencing homelessness that they were admitting into their hospital. And we asked them to keep track of that for 90 days. And then we took that data and we were able to determine how many of the 12 beds each hospital would be able to use. So depending on what percentage of the overall homeless population that was served in hospitals for those 90 days would determine the number of beds that they would be able to use. And then what we did was we took the overall cost of the program and then just divided it by the number of beds, and then that's what each hospital pays. So if a hospital is leasing 1 bed, then they're paying 1/12 of the overall cost. The county, for example, Ventura County, is leasing, or they are paying for 6 of those 12 beds, so they're paying 1/2 of the overall cost. So for the organization, the sustainability of this model was intact because the payment was guaranteed, and the hospitals were billed quarterly for this, so that this wasn't too much of a burden for them financially. And then they have access to those beds at all times, the number of beds that they have leased. That program allowed us to open, like I said before, in a much smaller community with a smaller number of hospitals and assure that that service was available. It's very reflective of the small community that it serves. And that program has been open now for close to 2 years, a year and a half now, and is being very, very much accepted very positively by the hospitals and the county. The healthcare has changed a little bit and continues to change, and what we're very, very excited about is our new lease model with health plans and health systems that we are currently starting now, and I think that probably will be the majority of our discussion today. National Health Foundation just opened last Monday a new 62-bed recuperative care facility, and with it, we've also really developed some phenomenal partnerships, two of which we'll talk with today, that have allowed us to create a leased bed model for this building. Healthcare is shifting tremendously, and the risk that hospitals take for patients is now shifting to health plans and IPAs, and so with that shift of responsibility and risk comes a different player as far as looking at the ROI for housing those that are experiencing homelessness. And so about a year ago, we started communicating with LA Care and also Dignity about the possibility of leasing beds to them in this new facility, and both are participants in that model currently. And what that allows us to do is several things. One is from a fiscal perspective, it allows us the knowledge that we will be sustainable, that we don't have to worry about a fee-for-service model, that we know that our program is sustainable. What it also does is it allows us a much better opportunity to measure ROI, particularly with our partnerships with LA Care, because the individual that we're serving, we can track them regardless of hospital, and we can see if their utilization of ERs or the hospital goes down. But finally, what the larger benefit is ultimately is the relationship that we can create and the individual program that we can create for each client that we serve. And so the partnership allows us to, instead of trying to put each patient or each individual experiencing homelessness into a box where they get the exact same services, we can instead work and be a part of a team with that health plan that will allow us to provide care that's best suited for that individual. So we can look at their needs, we can look at the barriers that they have to being housed, we can look at their utilization, their healthcare utilization, as you know, as how often they've gone to the ER, how much healthcare they're using, and then together we can create a plan that best addresses the needs of that individual client. So this is something that we are very excited about, not only from the fiscal perspective, but also from the service perspective. So I'm going to stop there, and I'm going to toss this over to Kim from Dignity and ask Kim to give you a little bit of a perspective as to, first off, who Dignity Health is, and then their rationale for participating in recuperative care. Kim?
Okay. Good morning to everyone. As you may have read in the newspaper, Dignity Health has merged with CHI, and we have a new name called Common Spirit, and that should all transpire the first of the year. So we're very busy trying to get all our hospitals licensed and become one with CHI. So we're excited about that endeavor. In terms of our recuperative care role in the community, we started with National Health Foundation 10 years ago. Our hospital downtown in Skid Row area, you know, obviously had a significant number of homeless patients that came through there. And as we tracked the number of patients 10 years ago to the number of patients now, there's obviously a major increase in the number of patients we referred back 10 years ago as opposed to the number of patients we're referring now. I also think that there's a bigger responsibility on the recuperative care centers to, you know, make sure that patients are connected to the HMIS system, the homeless management information system in order to get housing navigation so that once they have recuperated from their medical condition, that they are connected to some, hopefully, permanent housing, and to a housing navigator if their risk levels are high enough for them to get in the system right away. And that's a significant problem for Los Angeles, although right now with the new city and state and, and federal actually regulations that are coming down, there's becoming more and more opportunities for our patients that are experiencing homelessness to get into permanent housing. We've seen a huge reduction in readmissions, particularly on the acute side in terms of hospitalizations once we connected our patients to medical recoup care where they could provide them with, some healing recovery space. They could also connect them to housing services. They could also connect them to get their SSI, straightened out if they were eligible for it and get an ID, and sometimes reunify with family members they haven't seen in many, many years. This really, as we tracked it over the last 10 years, the reduction in readmission on the acute side was significant. Also on the ER side, it was a little less significant, but also significant, where we've seen patients that would have come to the ER, 14 times in 1 month would have been reduced to maybe 5 times or maybe 10 times. So even though that doesn't seem like a huge reduction, it is a reduction as it relates to them being able to connect to community services. So Dignity is a Catholic hospital system, and our mission is to connect with our community partners to work to support the vulnerable. And so, this is a big concern of ours and a big issue. Our CEO, Lloyd Dean, talks about it in lots of articles that are written about him. There's a recent one on LinkedIn, if you want to take a look at that in terms of his perspective, in terms of where we're going as it relates to housing and services and health care for the homeless and for folks that are poor. So, we have a really huge commitment to this population. We want to make sure that, they get what they need. I think there's a new trend in the world that they see housing as a part of healthcare. And with that, we see new state legislation, new federal legislation. As we look across the country at recuperative care programs, some are being federally funded in different states. I know in Arizona, the medical respite over there has become an FQHC, and they are billing for their medical respite services. We have seen a variety of different kinds of funding sources that are available, so they're not solely dependent on hospital funding. There's, private funding, there's philanthropy, there's foundations, there's social innovation partnerships, there's public health funding, there's medical homes funding from the state and the county, there's whole person care that has a housing component. So there's a variety of different funding sources out there, particularly in California, that have allowed more housing availability to happen, particularly with the HHH and H funding initiatives that are going on here in Los Angeles. One of the things that we look at Dignity, particularly, and I'll speak for Los Angeles for the most part, is that we want to ensure that the patient has a safe discharge transition to the community and in a way that they're going to be helped afterwards. And so we're willing to partner with whatever community partner is out there that's willing to help the patient to get to the final destination, and that is a well-being. We want to make sure that they get to their medical appointments, make sure they see their PCPs, make sure they get to the dentist, make sure they get all the places that they need to go in order to be able to have a well-being. So, and we know that living on the street causes early death and that people have to be housed. And so, one of the partners that we have is Center for Supportive Housing out of New York, where we did the 10th decile program out of California Hospital and worked with the patients that were high utilizers to house them immediately. We also have a social innovation grant that Dignity funded that's for the 6 Southern California hospitals, where we're housing patients for up to 2 years that are high utilizers and have medical conditions, because we want to make sure that these patients really get the services they need. And we know that a short stay in a recuperative care center is a necessary placement, but we also know that they need permanent housing in order to really get well. And so we want to try to make sure that we can be a partner in that thinking as we move forward with our new common spirit organization.
Thank you, Kim. I appreciate. I'm sorry, did I cut you off? Did you have anything else to add?
No, that was it.
Well, that was very good. Thank you. Thank you very much. I'll turn it now over to Dr. David Kagan, so he can tell us a little bit about LA Care's rationale for participating in the recuperative care program.
Hi, can you guys hear us?
Yep, we can hear you.
Okay, we got nervous because we got cut off from the audio for a second and called back in, but then we were muted, but we found some secret number to call to make it work.
Ooh, secret numbers are good.
Yeah. So I'm going to let Jessica talk a little bit first, just kind of about the history of LA Care and the thoughts about where we've been historically and kind of where we're trying to go directionally and where we see ourselves. To give people just a quick background, so LA Care is the largest publicly funded health plan in the country. We have 2.2 million Medicaid members, and that's not even on the Medicaid in LA County alone. So we see ourselves as having a large mission and kind of setting a direction and an example in terms of where we think and where we hope Medicaid policy is going directionally. And I'll kind of let Jessica talk a little bit more about just kind of our history.
Okay, great. Thank you, Dr. Kagan. So just briefly, I think on the following slide, I had put some history on LA Care's background and some of the planning and discussions around utilization of recuperative care programs. And I do apologize, I know there's a lot of text on this, but just wanted to make sure that we can cover it all. So I guess in 2016 is about when I first recall that LA Care began considering the recuperative care model. So that's the third bullet down here. We were in conversation with IEHP, which is the Inland Empire Health Plan, and they had developed a plan with the Illumination Foundation, which alongside the National Health Foundation is one of the big providers of recuperative care. And, they had basically leased up beds and had their own contract with the Illumination Foundation in order to place vulnerable individuals experiencing homelessness into recuperative care at the Illumination Foundation. And they were kind enough to share some of their contracts and their agreement and some of the work that they had been doing. At the time, under LA Care's current previous leadership, we had decided not to proceed because I think there was just concern about how to sustain that and whether that was the right financial decision at that point. So in 2016, we didn't choose to move forward with that particular model. Then in June 2017, that is Kim and others have alluded to, the LA County City Attorney and other groups and LA County Board of Supervisors through Measure H funding and the CEO Homeless Initiative, there's a great deal of influx of funding and attention and really pushing the problem and issues related to homelessness and how health and housing are related. And so some of these bullets just go through a very brief summary of some of what the LA County Department of Health Services through Housing for Health has been doing in the last approximately 2 years of really expanding their effort to address housing and homelessness and address the health needs through intensive case management services provided through supportive housing. So one of the ways that has looked is the LA County Department of Health Services. They operate a recuperative care program for high utilizers for selected Housing for Health clients. Their typical cost is $110 for a 4-month stay of 122 days. They use directly operated contracted recuperative care providers. And then also there's additional funding that became available mid last year in June 2017 here with strategies B7 and E8, and that refers to the CEO Homeless Initiative. So additional funding was available there. So this was yet another effort for LA Care to get more intensely involved with guiding people into the referral criteria and understanding eligibility for people who might be interested or might be good candidates to be placed by hospitals into these slots. But once again, we had some initial conversations with HASC and Housing for Health, but decided against proceeding with those plans. And so, as I understand it, in 2018, under some new leadership with Dr. Kagan and Dr. Seidman, we've really taken another look and relaunched some of these conversations with the National Health Foundation in order to provide support and financial undergirding to advance the 16-bed recuperative care pilot with NHS here, which is primarily what we're going to talk about today, but I just wanted to provide some historical context of, we've been looking at this for the past couple of years, but I think now is the moment when the problem and the policy solution have aligned in such a way that it seems like a good time for LA Care to really get involved, and as I've heard it called, dip our toe into the issue of how can we best handle medical transitions for homeless high utilizers who really need a better place in the ER to recuperate and recover.
Yeah, and as Kim alluded to, I mean, we're starting to see that the new state and federal legislation policies are moving in this direction as well. So by my background, I was a hospitalist for 10 years. The amount of people that would sit on my service while I was working in the hospital that couldn't get discharged, it feels like it kind of, that percentage just kept growing and growing over years. And if you really start to think about how do we get the people in the healthcare industry to operate at the top of their license, having these individuals sit in the hospital where they can't really get the social support that they need to actually get their lives kind of put back together, just doesn't make sense. And you've got highly trained nurses and highly trained doctors that really aren't providing, that can't provide care to other patients because they're trying to address social issues that they're not really trained to address. And it just kind of almost becomes just an unnecessary and just kind of a large expense. So really the question that we're trying to grapple with the most is, we see a role for ourselves to play in it. What we see is the role for the entire healthcare industry, I think, is still all being defined as well, and kind of who takes ownership and kind of who participates. Because, the health plans have a responsibility, the providers have a responsibility, the hospitals have a responsibility. I think we all kind of have a responsibility. How we all come together to actually have that coherent conversation to make this work, I think is going to be like the magic that kind of makes the thought about how do you actually really deal with housing issues like work. California is unique. We house, or house is the wrong word, but we have 25% of the nation's homeless. So the problem is much highly exacerbated here than it probably is in other states. It's an issue that we just can't really ignore because it's literally, as I even look out of my office on the street, like I see people living in tents on the street. So it's in our face all the time. So it's an issue that we have to deal with.
All right, thank you. Can you, was there anything else on the slide prior to this that we didn't cover? I think we went, Monique, we can go back one. Was there anything on either of these slides you guys wanted to cover?
I think this was just an overview of who LA Care is as a health plan. So just noting that we're a local initiative health authority of LA County in the 2-plan model here in LA County. So HealthNet is our other 2-plan model. Our coverage programs, LA Care Covered, which is through Cover California, Medi-Cal, CalMedi-Connect, which is the dual plan, and then PASC-SEIU, which is for home care workers or IHSS workers in home supportive services. And just making the point that we have 2 million members, and so we have a vested interest in really supporting the safety net and making the necessary partnerships such as this one with National Health Foundation, among others. I personally work a lot on the Whole Person Care and Health Homes program that has a component focused on homeless high utilizers. So yeah, that was all that was on this slide.
Okay, great. Before we go to the future funding potential, and we'll talk a little bit about that. I do want to take a couple of minutes and talk a little bit about the process that we have gone through with LA Care more specifically. Our partnership with Dignity is pretty long-standing, and Kim and I have worked together for a long time. LA Care was something that was new, and a little bit about how that partnership developed and how we got to where we are today. Obviously the beginning was just letting each other know about, letting LA Care know about our program. But once the decision was made and that they were potentially interested in participating as a partner, there's been several back and forth and a lot of discussions and meetings that have occurred to get us to where we are. And I can say from a provider's perspective, and then maybe you guys can chime in about from the healthcare perspective. From our perspective, I felt it was very important for us to be very understanding and flexible with the needs of the health plan, and recognizing that despite their desires and despite how much they want to participate, that regulations and guidelines make things difficult sometimes, and contracts can be difficult, and timing is more difficult than it is for a service provider like National Health Foundation, who is much smaller and a little bit more nimble. So being able to be flexible as far as forms that are going to be used, the way in which referrals are made, the services that we provide that may look a little bit different, the connections and the meetings that we will have as far as client follow-up don't necessarily meet the box or the way in which we've done provided services in the past. But actually, I think that they're enhanced, but but also really reflects the needs of our partner. And when I was at the Root Cause Coalition meeting just a few months ago, that was something that came up when talking about how to best pursue partnerships with health plans specifically, was the need for providers to be more cognizant and understanding and flexible when it came to the needs of their partner. So hopefully we have done that and we've been somewhat successful, but I do attribute that to the partnership that we've created and what was necessary on our side to make this work. I don't know if you guys, LA Care, you guys want to talk a little bit about that process for the health plan?
Sure. I mean, I think that we're trying to balance out kind of what are we willing to fund in terms of quote non-covered benefits, and how do we try to think about things that are services offered at recuperative care that be considered covered benefits. So for example, the amount of case management support that is offered recuperative care is actually a covered benefit. So we can look at getting some of the services that are provided within what we're paying actually covered, so it's considered within part of our rates in the state. So we are looking at trying to understand how we can leverage at least to break down what's happening in the facility to get part of that covered.
From the Dignity perspective, we are working with our IPAs that we have both risk relationships with and non-risk relationships with, and they have agreed to share the cost of recuperative care as it relates to some of the patients here in Los Angeles and also in the Ventura area. So we have worked collaboratively with our IPAs and our managed Medi-Cal groups in order to be able to help each other understand the benefit it is, recuperative care benefit is to us and our patients. So we have shared cost on that.
Thanks, Kim. So that's kind of moving us into the future of funding and the potential reimbursement strategies, which, Kim, I'm glad that you brought that up, that you have, the hospital has done that. Do you know, are there other hospitals that have also participated in that shared cost arrangement?
I'm not really sure about what other hospitals are doing, but I think that this is not a unique experience. I think that managed care, Medi-Cal managed care plans are looking at housing, particularly with the medical homes models that are coming down from the feds and the state. So, and across the country, there's a lot of collaborations with hospitals, managed care, housing developers, and so forth as it relates to trying to figure out the best housing solution as a part of the health solution for the patient experience homelessness.
And just to chime in, I mean, there's only so much I can say, but I can say that other hospital systems have approached us to have similar conversations to what Kim is saying about how can the health system and the plan partner together to come up with strategies on how we can take care of these patients. So I don't think it's just unique to Dignity. Other health systems are looking at this.
Yeah, I think we were talking about that a little bit yesterday about kind of coming to a head here in Los Angeles, and the need for the health plans and the hospitals and for everybody to come together, in the county for that matter, to come together and see how we can share the responsibility and the cost for providing care for those that are needed. In Los Angeles, like was mentioned before, I think our last count, we had 53,000 individuals on the street. So there are several people that are in need of care. Are there any final comments that either of you would like to make before we open it up for questions?
Yeah, I would like the council, the Homeless Council out of Tennessee is working on legislation to develop standards for recuperative care. And once those standards are approved by the Washington legislation, then the potentiality of licensure and funding is available. So it's an exciting time where we can see recuperative care becoming a more certified kind of a service with specific requirements so that the patients can get served appropriately and it can be monitored and it could be reimbursed. So I'm excited about that. And if any of you have seen the new legislation from the housing czar from Washington, D.C., he is interested in funding housing as a part of healthcare. So this is a very exciting time.
Yeah, I mean, I echo what you're saying regarding that as well. And I think one of the things that we have to think about is if you kind of wait for policy to catch up, like your operations are going to be behind. So, I take the stance of build the right operational model, prove that it works, and then the policy will catch up. But policy seems to always wait for proof before they get there.
Right, correct.
That's a great point. Well, thank you both very much. I think, Monique, we're ready for some questions.
Great. Thank you all so much for your presentations. Just to remind webinar attendees, if you have questions, feel free to type them into the question pane located at the right side of your screen. We have a few questions that have come in so far. The first is, what's the average length of stay for your clients, and who makes the decision that a patient or client is discharged?
So that's a great question. We have, I would say, historically, our length of stay has been around 14 days. We have done a lot of work in educating our partners and really trying to create with them defining, I would say, what the continuum of care is. And I think that Kim alluded to this a little bit earlier. Recuperative care, by definition, is not long-term housing. It's a place where our folks go, our individuals experiencing homelessness go in order to resolve some of the barriers that are in the way of them being permanently housed, and also to recuperate from their medical condition. So our goals when they get to us are threefold. One is that they'll be closer to housing when they leave us than when they got there, that they're better able to manage their own health, and that they're better connected to the community. And so our hope is that we have addressed those issues before they leave. As far as who determines the length of stay, in the fee-for-service model, it's the hospital alongside with the provider, with us. So when the referral is made, then the hospital suggests a length of stay. Our team will look at that to determine if we feel we can provide the care in that number of days. And if not, then we go back and negotiate, and that's determined before they get there. From the how we'll be working in the new model with LA Care is a little bit more advanced insofar as that when the client gets to us, they are going to allow us the time to do a full assessment, both nursing and social services, and then we'll be meeting on each of those clients within 72 hours of them arriving and collectively determine what the goals are for that client and how long their length of stay will be. So that will be a little bit more individualized. It also allows us to really, for us to get to know the client and get to do an assessment before we weigh in on the length of stay.
Thank you. Another question that we have is, how are you all tracking cost savings to help prove this ROI for this recuperative care intervention?
Well, this is Kim from Dignity Health. One of the things that we decided to look at cost savings is we took a regular Medi-Cal day of around $1,800 a day. If we didn't send the patient to recuperative care, that's the minimum that it would cost us for the patient to stay in the hospital. So we used that dollar figure times the days that they were sent to recuperative care to figure out our cost savings. Now, it's not a precise model of cost savings because we obviously would probably spend more than $1,800 a day on a patient that had Medi-Cal or an indigent patient that had no medical insurance whatsoever. But it gives us some way to figure out what the cost savings were. And, you know, over time, we've saved like $12 million by using that kind of cost-saving model to try to estimate, you know, what it saved us in order for us to refer patients to this service.
Yeah, we're looking at similar models as well. I mean, we're also looking at readmissions, trying to look at if we can predict, you know, using risk scores, how likely someone is to readmit to the hospital, and then looking over a course of 30 days what that delta is. It kind of helps us gauge in terms of what the ROI is. We also look as well, similar to what Kim was saying, you know, we're looking at how much are we paying for that necessary day in the hospital, and then trying to identify whether or not that money could be better spent elsewhere.
And I think that that's the exciting thing about the partnership across with the health plan is the fact that we can track an individual regardless of where they end up. We can track their healthcare utilization more succinctly, which would hopefully be able to give us the opportunity to look at actual ROI based on, like you said, the readmissions not occurring if we have a history of healthcare utilization from that same client. So recuperative care, for the most part, historically, has been able to show its ROI based on estimated cost savings, as Kim has discussed. So it's exciting to think that there are avenues for us to have more substantial data as far as cost savings for the future.
And just real quick, this is Jessica. I wanted to throw in that recuperative care, you know, is a piece of the solution, that those additional days that someone's in recuperative care allows for assessment of more permanent housing solutions in support of housing placement, and, you know, the process to get someone into the coordinated entry system and try to identify a housing resource that's a good fit through other programs, because that allows additional time for the person to be placed appropriately and linked to case management and that type of effort.
Yes.
Another question that we have kind of related to this ROI discussion is, do any of you see this type of model working for individuals at risk of homelessness as a preventative type measure, or really you must really see the cost first in order to capture the cost savings in the ROI, if that makes sense?
I think we're beginning to explore that. I mean, I think one of the things that we all focus on a lot is the high-risk population. We don't focus as much on the rising risk and how do we actually steer the tide of those that we start to see trends over time, costing more money, having more ER visits. They might not be going to the hospital 6 times a year or going to the ER 70 times a year, but last year was 5 visits. This year it's 8 visits. You know, next year we're predicting 12. So I think that we're starting to really recognize that we can't just focus on the people that cost the most, but how do we turn the tide of the people that are starting to cost the most? We're not there yet, but it's a conversation that's being had.
And for Dignity, we do have an ambulatory department where we have hired navigators and social workers that are working with patients that have serious medical conditions that we consider need some social determinant services in order to maintain their housing. And so this is a new program that we've instituted this year. So we will be working with those that we consider at risk for homelessness. Also, there's a program in Sacramento called Life Steps, and they are a social service program that works with housing developers. And they're a group of social workers that go into the housing development units and work with folks that are late on their payments for their rent payments, and they try to help them manage their medical appointments, their SSI appointments, buying food, and manage their budgets. And it's a different kind of model as it relates to the models that we see based on patients experiencing homeless. This is a group that works with folks that are in housing units already to try to keep them in their housing units. And it's a beautiful model, and they've been very successful and been over many years and working throughout the state of California and getting paid directly by the housing developers.
Great, thank you. Another question that we've gotten was, obviously, your three organizations are all based in California, specifically in Los Angeles. Do you guys see any unique circumstances or challenges that LA might prevent for some people to replicate or try and scale a solution intervention like this in other places?
Well, there are some technical assistance services that I would suggest. Center for Supportive Housing has some. They might want to look at those. And also United Way here in LA has a whole step-by-step process in terms of what they did in order to get the buy-in from the public and the city council and the mayor and so forth. So I would suggest that they, search our websites here in Los Angeles. They can start with the United Way website because they were one of the community leaders that helped to get some of these initiatives started, and be able to assist them with what they need to do. In also the Council for Homeless Services out of Tennessee has a lot of technical assistance that can help them.
And that's who I was going to mention is Kim, is the National Health Care for the Homeless Council. They definitely have some resources that are available if you're trying to start a medical respite program.
So going on this thread of if attendees want to start engaging in this type of intervention, you talked a lot about, many of you in your presentations talked about the need for private public partnerships, cross-sector collaborations. Dr. Kagan, you talked about how really organizations that are engaged in this work are looking to figure out if it's their responsibility to undertake social determinants of health and those interventions. What would be all of your biggest piece of advice to an organization that is interested in engaging in this type of recuperative care intervention?
I think it starts first with just identifying what are the resources in your community. So what actually exists that you can leverage and tap into to actually, if you wanted to start engaging in recuperative care efforts or anything else that might be considered a non-cover benefit. It's just first understanding what's in your community a little bit, and I will defer a little bit, Kelly, to you and your team about how to help other health systems and providers navigate how to identify what's in their community. But I think you also can look at what for the members that you currently have, like, where is your spend on maybe administrative days, and how can you begin to understand, what is an amount of money or that we could allocate for a year based on kind of what we're spending, but we don't really think we're getting a lot of bang for our buck back, to begin to think about how to budget it out.
I think that. Go ahead, Kim, please. No, go ahead, Kim.
I would suggest that you look at the current shelter programs in your community and determine what their bed capacity is and whether or not they have an interest in a recuperative care center, because they already are working with the homeless. They already have an affinity, hopefully, for the homeless. They understand the conditions and the needs of the homeless, and so it's better to work with someone who has worked with this population as opposed to a new vendor that might not be as understanding or knowledgeable about the needs of this population. There's still a lot of stigma and discrimination as it relates to homelessness. Many people think that people are just lazy or they're just drug addicts or a variety of different kinds of thinking that goes on as it relates to this population. So my suggestion is to go where people that really truly understand this population and see if there's some ability to build some bandwidth. And then whoever this population hits, if it's the fire department, the paramedics, the county hospitals, the local hospitals, all of those are potential collaborators as it relates to working with this population.
Great.
Kelly, did you have an answer to that as well?
No, I think Kim covered it. Kim and Dr. Kagan covered it.
Awesome. So another question that we had was, Kelly, you talked about how one of the things that you've learned in engaging with cross-sector organizations to implement this intervention is that providers need to have flexibility and be receptive to the needs of their partners. Can you talk about what are some tangible ways that you have seen providers be flexible in this type of collaboration?
Well, I can speak from our perspective and what's needed from our end. I know that, for example, our partnership with Dignity, that there are reporting requirements that make their lives easier. Kim and I have been through many a billing iteration with Dignity and how they needed things to be billed collaboratively amongst hospitals separately. So we had to be flexible there in what was working for the hospital and what was working for their corporate system, and then what reports that they need. Other partners that we have, they want every client to come in for the same number of days, and they can't be flexible on that end. So we have to try to work around that. But we have other providers that have specific forms that they would like to have filled out for their patients that come to us, and so we have to have several different forms on record that are used for depending on who the payer source is. So those are just a couple of examples, but so we have to be open to all of that. We can't just say, no, it's our way or the highway, because, health plans and hospital systems are immense. And the provider really has to have a lot of respect and understanding for for that process and what we don't know about it, and be able to shift accordingly if possible.
Thank you, Kelly. A logistical question about the model itself. So are you able to co-locate outpatient medical services at the recuperative care site, or do you have to coordinate transportation, and how is that accomplished?
So we can recuperative care is unlicensed and unregulated. So, we cannot provide direct medical care. But we do partner with those that do. For example, if somebody has a skilled need, then a home health representative can come into the recuperative care site and provide home health services at the facility. We personally, right now, as far as transportation is concerned, we help some of the health plans provide transportation, but otherwise we use what's Uber Health out here. There's also other transportation services that we use, and then some recuperative cares have their own transportation. But we also provide, have to work with other providers as well. I mean, like a food vendor, and there's lots of different vendors and services that we have to bring in to be able to provide the care. But as far as the medical component is concerned, home health is definitely something that we depend on, and the hospitals depend on too, in order to send us those clients that really would just suffer tremendously if they were to go back to the street, but don't have a need to stay in the hospital. And they really are the ones that are the most vulnerable.
Thank you. Another question, again, a logistical question is, can you talk about the front-end entry to the recuperative care? Is it determined through the homeless coordinated entry system, or is it determined by the health plan for those individuals?
I'm sorry, you mean like how it's determined who gets to come to the program?
Correct. Yeah.
So that is up to the hospital or health plan that's leasing those beds. So a process is, we have to determine a process with the partner as to how they will decide who goes into those beds, and so that's kind of individualized based on the partner. But in the leased bed model, those beds belong to them, so they can determine that. For example, Dignity Health has 5 different hospitals that are utilizing their leased beds, so they have an internal process to decide, what patient or what individual will be utilizing those beds. From the provider's perspective, it's our job to make sure and determine that individual meets criteria, meaning that we can provide the care. And so we do that depending on the partner with whoever, if it's with the individual hospitals or with the health plan. But those that are leasing the beds are really ultimately the ones that determine who uses them.
In the county programs, they do enter through the coordinated entry system for the recuperative care beds, but not in the private programs.
That is correct.
Are you screening for homelessness or housing security? You bring a patient in to utilize your services? Kim?
Excuse me, could you repeat that?
Yeah, I'm sorry. So I just was curious as to if Dignity is using some sort of screening tool to determine if their patients are facing homelessness or housing insecurity.
No, we are collecting the homeless data based on our registering patients in the hospital. Sometimes we get accurate information and sometimes we do not. But there's a social worker assigned to the patient that does a psychosocial assessment that determines what the patient's going to need when they leave, and if they have a medical condition that we don't feel is safe for them to be able to manage on the street, and they are willing to go to recuperative care, then we refer them to recuperative care. So there is internal psychosocial assessment tool that we use inside of our medical records that give us some ideas, and then in our discussions and assessment with the patients, they have to agree to go, and if they agree to go, then we refer them over to determine whether or not they'll be accepted into the program based on their medical conditions.
Great. Well, thank you so much to all of you. Do you have any final thoughts that you want to provide our attendees with before we conclude today's webinar?
Oh, I did want to say that there are some medical respites that do have FQHCs connected to them. And some of the medical respites, there's 2 I know of in the country, one in Arizona, one in Boston, that have FQHC licensing. And they're able to bill for the medical services they provide in their programs. And there's several here in Los Angeles that have FQHCs inside the same building with the medical respite service.
I mean, I think the one thing that I can say is don't be afraid to try something new and kind of step outside the box of what policy dictates if you think it's the right thing to do. Because the more that we demonstrate that projects, the things that we know instinctively are going to work, the more we know policy is going to catch up. And I just don't want to be waiting too long for all of us to be waiting for policy to actually get us where we need to be.
Kelly, any final thoughts?
I would just say to anybody who's a provider on the phone to reach out to the health plans and to the hospitals in your community that healthcare is changing very rapidly, and so is leadership in these institutions, as evidenced by the two on the call today, and that what didn't work last year doesn't mean that it won't work this year, and you very well may have partners that are ready to move forward and can move forward.
Thank you all so much for participating and sharing your stories and your experiences with this social determinant intervention. Thank you all to the attendees of this webinar as well. I hope you have a wonderful rest of your Tuesday, and at this time I'm going to conclude the webinar. Thank you all so much.
Thank you, Monique.